Representing the Nordic lymphoma group, who carried the largest studies on this question, I would tend to support the idea of autologous transplant placed as much upfront as possible. This has also been supported by some large retrospective analysis, for example, of the International T-cell project, that if you want to perform an autologous transplant, then rather upfront than later. The case is different if we talk about allogeneic transplant. Allogeneic transplant is a modality which is very effective in T-cell lymphomas, but unfortunately also correlated with a rather high treatment-related mortality or toxicity. So there was a brave clinical trial carried out by the German lymphoma group, high-grade lymphoma study group, that compared autologous versus allogeneic transplant consolidation up front. That trial was recently stopped prematurely because of, or as a consequence of a futility analysis. But the allogeneic transplant cohort was burdened significantly by toxic deaths. So our present view is to perform autologous transplant as an upfront consolidation strategy, and in those patients that relapse, apply allogeneic transplant if you can bridge with something meaningful to it. And that's where the new drugs come into the picture, the ones that are approved for second line. And right now we are awaiting interesting clinical trials that test new drugs in the first line setting.